Hey gang, so chapter 3, we're looking at patient autonomy. So there's two concepts here to think about. The first one we're looking at is how to respect a patient's autonomy, and also how we need to think about controlling the release of their health information. So we're going to review HIPAA a little bit here as well. So autonomy means that the patient has the authority to make decisions about his or her own life. The patient has control over their personal information and over their personal decisions. It is our professional duty to ensure that we give them information necessary to consent to services, that we tell the truth, and that we maintain confidentiality at all times. So there's an idea here of moral autonomy. The patient has the moral authority or right to make their own decisions. And psychological autonomy, and that's assumed or presupposed when a person exercises their moral autonomy. It is the competency to make one's own decisions and the ability to reason and act rationally. So infants or a patient with severe Alzheimer's disease, for example, lack autonomy in this sense. They lack psychological autonomy. And then competence. Competence refers to the psychological ability to make decisions about one's own life. So again, infants and severe Alzheimer's patients could also be considered not competent. They are not psychologically able to make decisions about their own life. Two concepts to look about here. We're going to compare and contrast paternalism versus autonomy. So paternalism can also be thought of as like parentalism. And I tend to gravitate more towards that term, but let's break down a little bit. So historically, the historical pattern in our Western culture and in Western medicine is to follow the Hippocratic Oath. Basically, it's taken for granted that most physicians know better than patients what's good for them regarding their health. This is considered medical paternalism. I know so much as the doctor, for example, the doctor knows so much more than you, the patient, that the doctor has the right or the duty to make decisions for you. So medical paternalism, the viewpoint would be from the doctor. I know so much more than you, patient, that I have the right or duty to make decisions for you. Weak paternalism means interfering with others to stop them from being harmed. For example, someone stopping someone from walking into traffic, or like it's necessary to use a helmet when you're riding a motorcycle in Washington State. Moving objects out of the path of a blind person so they don't get hurt, assuming that an individual with a disability needs your assistance, or required flu shots. Again, I like to think of paternalism more like parentalism. A parent would make decisions, usually, hopefully, to stop their child from being harmed. In contrast with strong paternalism, this is where interfering with one's liberties to promote their good, but you don't have their permission. So like making a patient participate. For example, giving a person a placebo to wean them off of an addiction. Yes, it interferes with the patient's liberties of having a choice, but it is for their good. Code of Conduct Standard 2A states that a PTA shall act in the best interests of the patient or client over the interests of ourselves as PTAs. We're starting to see a shift away from really strong paternalism towards a respect for patients' autonomy. And I think that's a good thing, a realm where a PTA can have a lot of voice to help inform a patient so that they can make independent decisions about their health. Now, I know the text is old, okay? It talks about AIDS in a lot of the examples. So it was you can interject more current medical conditions, if you will, but the concepts and the ideas remain the same. Here's a little funny cartoon, I think. So here's, this is a nurse. So asking the patient, what time would you like to get out of bed today? Patient, I wouldn't like to. How many feet do you think you could walk in the hall today? 0. I saw you, and then here's her coworker. I saw you marching your patient down the hall. What happened to mutual goal setting? I decided that paternalism is more my style. So it's the idea of like making them do it, right? Because we think we know what's right or good for the patient. So we need to talk a bit about informed consent. So informed consent, there are 4 pieces, if you will, to it. So informed consent is a healthcare procedure considered mandatory in which, so the first part is mandatory, in which a patient is supplied with information about a procedure or a treatment that a healthcare professional feels is warranted given the patient's status. So it is assumed that the healthcare professional is knowledgeable concerning the patient's status and also knowledgeable about the possible procedures and interventions, if you will, and supplying sufficient information to the patient for a rational decision to be made by the patient. We are in a partnership with patients all the time. We're not just telling people what to do, right? Patients always have a right to know the identity of all the medical caregivers involved in their care and their status. As a patient, if something unexpected, I wrote this slide from as a viewpoint, from a viewpoint of the patient. As a patient, if something unexpected happens to you, you will be told and be part of the discussion about changes in care. The patient may tell caregivers if you need more information to make a decision, and then the doctor will explain the medical consequences of you refusing treatment. You could interject that the PT or PTA could explain also what might happen if they refuse treatment, and the patient has a right to receive a notice of privacy practices, and the patient has access to read their own chart. So informed consent is more than just a one and done, sign a consent form like the release of information on HIPAA form. It's an ongoing process. This means that at any and every time during your treatment, the patient has a right to know what you're doing and why you're doing it, and a right to refuse. The patient never has to participate in therapy like, the nurse marching the patient down the hall. The patient always has a right to refuse. We're going to talk about the different components to informed consent next. First, I wanted to give you 3 legal concepts involving informed consent that you need to be aware of. So disclosure is the legal right of a person to be informed of what will happen to them. A fiduciary relationship is one that's based on trust, fidelity, and loyalty. A person in whom another person has placed in a special trust or confidence to watch out for the best interests of the other party. Okay? And battery is this idea of the act of offensive touching done without the consent of the person being touched, regardless of intent. In your text on page 30, in the little box, it's case 3.2, highlights a case study where even just range of motion treatment, it was painful to the patient, could be looked at offensive touching and possible battery. So those 3 legal concepts of informed consent, will just keep those in mind as you're reading through some of the case studies this week. You can give forms of consent can take different shape, if you will. It could be written, could be oral, could be general, or could be special. An example I can think of, like for performing Graston treatment, patient needs to sign a specialized consent form saying that they know they might get bruised as a consequence of that. So Code of Conduct 2C states that a PTA shall provide a patient or client with information regarding the interventions they provide. And how you obtain the consent, again, maybe any of these types of forms of consent: written, oral, general, or specialized consent. So the first condition or component, again, keeping in mind those legal concepts in the back of your mind here. The first component of informed consent that I want to go through with you starts on page 29 of your text. The first condition of informed consent is information. The patient should verbalize understanding. We need to be careful that we're conveying the information carefully in a way that the patient can understand, not just merely spouting off a list of facts or talking over their head in overly medical jargon. You need to remember that disclosure is the legal right of the person to be informed of what will happen to them. You want to also be cognizant of language barriers or cultural differences here when you're giving out information. The second condition, as on page 30 of your text, is called voluntariness. I don't know. This means that the patient must be free to make decisions without being coerced or otherwise manipulated. So it's voluntary. And competence, the third condition or component of informed consent, means that patients must be sufficiently rational or competent to understand and make healthcare decisions. Again, I mentioned we want to be sensitive to possible language barriers or cultural differences here as we are, ensuring that our patient understands what we're talking about. We'll also want to be aware of how patient anxiety or distress could play into their understanding of information. Maybe you've experienced in your life when you've been in a high stress situation, you don't quite get all the facts. You maybe hear the first word or two, and then everything else sounds like that lady from the Charlie Brown, Peanuts character, in one ear, out the other. Again, we want to be cognizant of not using too much medical jargon. We also don't want to speak down to our patients either, though. And health literacy, this is an idea that's hopefully you guys remember from 101 way back when. Health literacy is the idea that, and I put some videos in the module for you to watch, that the idea of the patient, we're trying to help people become literate in their health conditions so they can make good choices regarding their health, right? We're teaching them about their condition and the course of the diagnosis. The idea is the more that a patient knows about their overall health and the overall condition, hopefully, that's encouraging them to make good choices. Yes, and we also want to be careful too of what assuming things that we think a patient should already know. Like, we know that shoulder bursitis goes like X, Y, and Z, right? But the patient maybe doesn't know that's what's involved in their condition, okay? And we also want to be careful of making educational assumptions, either regarding where the patient is or isn't in their educational level. So take some time this week to watch those health literacy videos too in the module. They are fantastic. So disclosure standards, there's this idea of a medical care standard, that information that healthcare professionals in a region agree is important for people to know. This is a very timely situation in the world right now is COVID-19, right? Like there's a standard, medical care standard that we as people in, say, the world need to know what the mode of transmission is, if you will, for COVID-19, what the basic outcome is, all that kind of stuff. Reasonable person or patient standard, this states that relevant information that any reasonable person would want before making a healthcare decision. So if I talk about the COVID-19, I would say that, yeah, I would want to know what happens if I need to be on a ventilator. What's the outcome of that, right? Reasonable information that relevant information about the condition that any reasonable person would want before making a healthcare decision. I don't know they necessarily have a choice to go on a ventilator or not with COVID-19, but that's kind of beside the point. Patient-centered standard, it states that the patient and the healthcare provider converse about what the patient wishes or needs to know before making a decision. So generally in Washington State, we follow the reasonable person or patient standard. Certain areas work hard to move towards the patient-centered standard. I feel fortunate that we generally follow this in Washington State. Let me ask you this: which would you consider to be the most ethical standard? I think that's a personal question we each have to answer. I don't know that there's necessarily a right or a wrong. I tend to think that maybe it's good to have a patient-centered standard where the patient and the healthcare provider converse about what the patient wishes or needs to know. Maybe the reasonable person standard is the most ethical. I think you could make a fair argument for that also. Certainly, the patient needs relevant information before making a healthcare decision, yes? Voluntary consent is this idea that the patient participates with healthcare voluntarily. So again, a patient has the right to deny treatment at any point in time, and always make sure you document that and document why also that they are denying treatment. The patient speaks for themselves. Coercion can be considered, so no coercion is used to compel the patient to go against their own wishes. So, I put that cartoon in here as kind of a joke, but really that could be considered coercion, right? If you are making the patient get up out of bed and walk down the hallway if they've already stated that they really don't want to. I think I tend to try and ask a couple of times, but I never force, right? So and a lot of it has to do with your tone of voice, right? Coercion can be considered the tone of your voice. Can be considered how you structure the information or present the information that maybe subtly influences the patient, try and get them to go along with what you want. Competency refers to the idea, again, that there's this level of mental capacity, skill, and reasoning and rational conduct that the patient has. So the patient has the ability to be considered competent. The patient, so remember, like a newborn or a severe Alzheimer's patient could be considered incompetent. Patient has the ability to consistently communicate their choices consistently. Ability to understand the information on which a choice is based. The patient has the ability to appreciate the situation requiring a decision according to their own values, and the ability to weigh out various values to arrive at a decision. There's this idea in your text, and I don't know that I love this terminology, but the idea that some patients are never competent. So newborns, children under age 18, there are some exclusions to this, varied by state. This means that basically healthcare decisions are made by a child's parents, yes? Patients who have never been competent and have a appointed legal guardian would fall into this category too. Maybe they're severely mentally disabled from birth and not able to make decisions for themselves. One of the challenges when working with a patient that's considered in this category is that we still have the goal of needing to determine who can speak for the best interests of the patient who's never been in a position ever to voice his or her own wishes. So possibly the parent is not the best choice, depending on the situation. Usually it is, but maybe an appointed legal guardian is a better choice for the never competent patient. Yes, it totally depends on this individual situation. And then what do we do with a patient who was once competent but now is not, say from brain damage or severe mental illness? A legal guardian may also be appointed for them. Legal guardians are sometimes known as substitute decision makers, right? So a substitute decision maker, or a legal guardian must have taken on, so in essence, they've taken on the autonomy of the person that's under their care, either by a written or verbal statement. Maybe it's a power of attorney. They, to be considered a substitute decision maker, like a spouse, for example, who's making decisions for a now brain damaged partner on life support, must have intimate knowledge of that person. So a parent could be considered having intimate knowledge of their child who's maybe now on life support. The guardian or substitute decision maker should always be considering what is in the best interest of the patient, who once was competent but is now not. The challenge here is to attempt to make the decision on the basis of what the person would have wanted when they were competent. So obviously you need to have, as the substitute decision maker, you would need to have some very good intimate knowledge of this person and their deeply rooted desires and wishes. Yes? Do they want to be on life support forever? Do they not? So to disclose or not to disclose, when we talk about what the patient needs to know, that is the question. I'm going to just say, be ethical, tell the truth in all situations. The ethical principles that are involved in the debate around whether or not to disclose information to a patient are veracity, that's telling the truth. Beneficence, we have the duty to act in the patient's best interest. We are also going to consider the ideas of patient autonomy and paternalism. Who has the authority to keep that patient safe? Who has the authority to disclose information? And non-maleficence, doing no harm. So Code of Conduct Standard 4A says that PTAs shall provide truthful, accurate, and relevant information and shall not make misleading representations. So being truthful with patients is a key component of the trusting, loyal, fiduciary relationship. A person in whom another person has placed a special trust or confidence in to watch out for the best interest of the other party. Again, that's a fiduciary relationship. And it can be challenging to tell the truth in every single situation, yes? You can look in your text on page 35. There's an example of a patient that has cancer. The doctor and the spouse determined not to tell the patient. The patient asked the PT then if he has cancer. And then for a counterpoint, it's a different chapter, but you can look at page 163, so where the PT actually lies to protect a vulnerable adult from an angry spouse. So telling the truth in every situation can be challenging, and it's, is it in the patient's best interest to tell a little white lie? Maybe, if it protects them from an angry spouse, yeah? If somebody speaks a falsehood, have they spoken out of a lack of knowledge or out of an attempt to deceive. So keep that in mind. Again, Code of Conduct Standard 4A, PTA shall provide truthful, accurate, and relevant information and shall not make misleading representations. So I guess you have to look at what's the motive behind it. Is it simply you just didn't know, or were you trying to deceive somebody? If patients begin to believe that we don't protect their confidentiality, then they're going to cease to tell us what we need to know. Okay? So, confidentiality is the practice of keeping information that's harmful, shameful, or embarrassing within proper bounds. Of course, it's built on a relationship of trust. We've got some ethical principles that play in there, same that we've been looking at already. And respecting a patient's confidence is an ethical duty. It's also a legal obligation, reviewing HIPAA, okay? Code of Conduct Standard 2D, PTAs shall protect confidential patient-client information and, in collaboration with the PT, may disclose confidential information to the appropriate authorities only when allowed or as required by law. So when we're considering what we can and can't share, remember that information sharing among healthcare professionals is aimed at facilitating the optimal care of the patient. So you can disclose some things if it's necessary for you or the other healthcare professional to do their job. So it's a minimum amount of disclosure. We are excluding any unauthorized people from finding out confidential information, like the people that clean your clinic at night or on the weekend. And remember that we do have, as PTAs, we have a limited legal entitlement to protect a patient's personal information in a court of law. What that means is that sharing information during a trial, during a legal process, is necessary, but you may be putting yourself at risk of violating HIPAA, violating a patient's confidentiality, when you're sharing their information, okay? So again, we divulge only what's necessary. It's a minimum amount of information that's necessary to be able to do their job, and that we try to maintain reasonable safeguards of divulging information, okay? When we talk about modern healthcare, modern healthcare creates this need to know and legitimate interest situation. For example, third parties that are doing billing need to know patient information. Auditors, Medicare auditors, whatever, need to know patient information. Pre-qualifiers, who is getting the patient their script for therapy, okay? There are some people that need, especially in modern healthcare, there are some people who definitely have a need to know and a legitimate interest in patient information. And patient care information systems allow for substantial amounts of a patient's information to be contained in one place. That's good. So there are third-party information warehouses. They actually call them health clearinghouses that actually store a patient's information all in one place. It's like a big old web mix, sort of like I imagine where your emails go, on this server. Same stuff happens with your patient information. So luckily, things are password protected. When we're working with electronic medical records, we are making sure that we have passwords. I actually get my work email for signature on my phone just for ease, so I don't actually have to log into my tablet, but I had to make sure that I have an extra level of password on my phone because there could be potential patient information. As a matter of fact, there is. They send out hospital reports on secure email, but because the fact that I'm checking it on my phone needs to make sure that I have a password protection. It's really annoying, but I have to do it. My phone times out every 30 seconds, so I have to put my password in. But I choose to do that so I can get my signature email on my phone, yes. Making sure that you're checking, always doing your documentation and checking emails, whatnot, in private areas. Laptops or tablets are held securely or put in places so tablets are handheld, or laptops are in places that other people can't see notes, and that computers should time out after a short time of non-use. Again, 30 seconds is kind of the standard that Signature chooses to follow. And just keep in mind, too, that we are required by law to report. We're mandatory reporters for child abuse. Some other legal reporting requirements could be if there's a communicable disease, if a person has injured themselves with a gun or knife, harm to themselves or others, blood transfusion reactions, poison and industrial accidents are required to be reported, and also misadministration of radioactive materials. So if you ever find yourself, messing around with plutonium, somebody might report you. Okay. Keeping in mind that the penalty for breaking HIPAA is huge. So check this out. Did you know you can actually get like a $50,000 fine? This is per incidence, okay? That's civil. Criminal penalty. So if they find that you have disclosed patient information knowingly on purpose, then you can, range from $50,000 and a year in jail up to $250,000 and 10 years in jail. So you guys, it is a big, big deal. Don't break patients' confidence. Okay, if you can at all 100% avoid, disclose only minimum necessary. Is a review. I did put a page in the module for you to look at some HIPAA facts. So consider that as you are working through your module content for this week. Sorry, this lecture ended up kind of long. Anyway, that's it for now. See you next week.